Today, our side will be discussing the items we reviewed during our consent audits. And those can take place either in a full regulatory review, or it can even be specific just to consent reviews. In fact, sometimes we go out just to see how things are going. They can be kind of complicated, so we like to help. I mean, that's in effect what our audits are about. So we'll be discussing those items that we review. And what I'd like to emphasize is that consent audits shouldn't be just left to us, to OCP. It's something that should take place by study teams, while conducting the clinical trial, throughout the clinical trial. And so with that in mind, the goal of our audits is to provide you with the information that can help improve consent practices, participant protections. So we always want to keep that at the forefront. Risk reduction, that's always helpful. That makes me nervous, risk. And compliance with the ethical and regulatory standards in clinical trials. So that's what we're going to be doing here. Let's see if I can get this. Yeah. So we'll be covering the purpose and importance of consent audits, and then the key compliance issues that we review, or components, pardon me. And we'll discuss some of the best practices as outlined by Good Clinical Practice, GCP, and the Alcoa principles. And then lastly, we'll point out the benefits of conducting these consent audits from our point of view, and show why we think this process should be included, as a systematic task, meeting for you guys while conducting the study. Okay, so yes, consent audits, they make things better. They help us determine the compliance with consent guidelines and the regulatory requirements. They help identify areas for improvement, and that leads to better consent process and documentations. And that in the end run enhances participant trust and safety. I think the most important thing. Let me give you a couple of examples, for instance, what can go wrong in the consent process, so you understand why it can be so important. So for instance, if you use the wrong version or an expired consent, when obtaining consent from a participant, you can possibly cause harm to that participant, and that can even erode participant trust. So for instance, what happens when a new version of a consent adds additional risk, but it isn't used? So these changes might have serious implications to the participant, which could affect their decision either to join or to quit if they're in the study. Very important to use the correct versions of consent. Another example, and this goes to our UCSD P30 that's such a mouthful, which has to do with informed consents for research subjects. And it requires that consent and HIP authorizations are uploaded into the participant's medical record. What can happen if it doesn't go in there? Other service providers that might be providing care to that individual may not know that their patient is actually taking a study drug, and that could lead to serious problems for participants' health and welfare. So important to always pay attention to versionings, always important to know the process and track what it is that you do. You have to take this very seriously. The bottom line is that conducting these regular consent audits, it can mitigate legal and ethical risks. And just so you know, regulatory violations can lead to suspension or termination of your research study. You can lose federal funding and even fines and penalties for our institutions. So it is a big deal. Lawsuits can occur due to inadequate consent processes, and those can include malpractice lawsuits, claims of negligence, financial damages, none of which we want to get involved with. And then ethical risks can violate participant autonomy and can cause physical and psychological harm, and even in fact damage the scientific integrity of the study results. So that's the importance of of why we do these things, and why it's, I think, important for you all to make this, part of your day. And a little water here. So key components. Want to make sure, and this goes to you, Casey, that our consent audits are apart from the informed consent review and approval process that OIA conducts. And so with that, we evaluate the following key components. I have a few listed here. And so we talked about this. Was the current OIA approved consent form utilized? We've seen in the past that it hasn't been. That's a problem. Reconsenting is another issue. Was it obtained if required by OIA approved protocol amendments? We talked a little bit about that and what the effects could be if you don't. Were proper signatures provided by both participants and consent obtainers? And can you read them? It's very, very important that legibility in consents is maintained. And then always a good one here is, did the PI delegate the study staff who obtained consent? That needs to be documented somewhere. That can be done in a DOR, or delegation of responsibility log, or in the protocol. But we need to know that, and you need to know that whoever's obtaining consent has the proper background and understanding of the protocol and what's required for obtaining consent. Another one is that we look at is to see that the HIPAA research authorization was obtained at the same time and date of the initial consent. And then along with that, if the UC HIPAA authorization, the current UC HIPAA authorization was used. We still see, even now, 2013, HIPAA authorization versions that are being used. So we just be aware right now, at this point in time, 2014, I'm sure I'm singing to the choir here, but I thought I'd bring it up. And then if the experimental participants' Bill of Rights is required, we need to have some sort of documentation that was provided to the participant. So I'm just kind of moving along some of these things very quickly. So another one, we talked about this one, signed informed consent and HIPAA authorization uploaded to the participant's medical record. So that means you're, if per 340.1, the informed consent for human research subjects dictates that needs to be done, then we do look in EPIC to confirm that they are in place and that they are in place prior to the first study activity. So it's a date thing and knowing that they're in there. So those are the two pieces we really look at. We also look to see that all the versions of the OIA approved informed consents are in the regulatory binder, and all applicable signed informed consents are in the participant binder. So we like to see both. We want to see the history of the consents, the changes, how they marry to amendments to the protocol, and the fact that you have them there, it tells the story. And then obviously I shouldn't say obviously, but then the participants in their study binder, you have a record of their signed and dated informed consents. And then lastly, we do like to see, and I think this is an area that could be improved in many of the reviews that I've conducted, that there's a documentation of the consent process. And I don't mean documentation from OIA's perspective. I'm talking about that there's documentation that screening and eligibility is in place and documented. What the process was that you went through, what you talked about during the consent. That can be done with a checklist or any fashion, but I think it's important to really expand on the fact that this is a consent process that took place and put it in the binder. So that would go into each participant's binder. So it may seem simple, this list, but it really gets deep in the weeds sometimes when you really start looking at all the components that are involved with consent. And many times we do find room for improvement in these areas during our reviews. Okay, take a breath. Pardon me. So here are some of the best practices that you might want to keep in mind in the informed consent process. We've touched on a few of these. The principal investigator must authorize a designated individual to secure informed consent on their behalf. So I think that's important. It's on their behalf, the PI. So they need to delegate that. And that delegation should be given only to people who have been trained and have knowledge about the protocol. And in the opinion of the principal investigator that they have the wherewithal to do so. Prior to participation in the trial, the participants should always be given a copy of the signed and dated informed consent. That might include the HIPAA authorization and participant Bill of Rights, and then keep the original documents in the study record. Next item would be informed consent. It should be obtained prior to the start of any study activities. And I think this is important to note that if the informed consent is obtained on the same date as the first study activity, put a note to file in the study subject's record stating that the consent was obtained prior to that first study activity. That way, it's very clear that it was done in the appropriate order. I would recommend also maintaining a log of the informed consent versions in the regulatory binder. That is a useful tool for you to know that you're keeping track of the versions and that you're in fact using the correct versions. And it also makes it audit ready. It makes your life easier if you're ever reviewed by an outside agency. We also recommend that you file them in reverse chronological order, and to also include the HIPAA authorization and Bill of Rights, just all in a stack. It tells the story. And then finally, it's just following Alcoa C, I shouldn't say just, but following Alcoa C principles and GCP guidelines. And that goes for both paper and electronic records. So, we talk a lot about GCP, and there's just so many guidelines and regulations, I suppose you'd say. But Alcoa C, people don't really, I think, understand the acronym so much, but it's a set of principles that ensures that the clinical trial data is reliable, it's traceable, it's high quality, tells the story. So I thought I'd bring out a few items of best practices for that also. As always, making sure signatures and notes are legible, very important. And it would be good to be able to trace signatures and to have a log, whether it's on the DOR, which is a really good place to have, but to actually have a signature that we can trace back to who that person is. I don't know about you, but I know when I read doctors' notes or even signatures, it's impossible to know what it says. So if we have a way to trace that, and you have a way to prove that the people signing the documents, or not to prove, but to be able to track back to who the person was that provided the data and the information, is very helpful. When making a correction on any of the forms we use, the HIPAA or the consent, or any forms for that matter, if you have an incorrect entry, don't obliterate it. Don't mark it completely out. It's a single line through. This is going way back to the basics, but a single line through it, and initial and date, and if appropriate, provide a reason for the change. I mean, there might be a reason that you need to tell about why that change was made. You can put in a note to file. You can do it right on the document if it's easy and it doesn't get in the way of legibility. And then lastly, use dark ink. Don't use whiteout or pencil. Those are two no-nos. So with that in mind, I thought I'd just go through the acronym a little bit. So A, attributable. So what that means is we want to know, that it should be clear who documented the data, who entered it, and when. So that's very important. Legibility, always important. You should be able to read things. Signatures are identifiable. You can understand what the data is. Contemporaneous, that should be information is recorded in real time as it happens. A lot of times people will go back 2 weeks or 3 weeks or a month after something was recorded and enter it. And that leads I guess that leads to errors, entry errors. You're relying on memory a lot of the times, or notes that maybe not be complete. So always good to get that information recorded as soon as it happens. Original. The reason I bring that up is that we need to have original records, or they can be certified copies, but they should be used and not photocopies. And then accurate data should be accurate and a consistent representation of the facts. So it's like a story. It's like writing a book. And then complete, which they added not too long ago, is that it should answer the questions of who, what, when, where, and why, and how the information is being presented. So these are really the framework to maintain a good high standard of data collection and management in clinical trials. Excuse me. So as we mentioned at the beginning of the discussion, by systematically reviewing and improving consent practices, you can enhance participant protection, you can reduce risks, and you certainly can ensure compliance with ethical and regulatory requirements. Now, this should be ongoing, as I've stated, I think the third time now, and it should become a matter of routine. And why is that? Because they improve adherence to regulatory and institutional requirements. It enhances staff training. You learn your mistakes and how to make things better. You provide better participant understanding and engagement this way. So you're not having to say, oops, I made a mistake, sign this one instead. Reduce legal and regulatory risks. And then you increase the transparency and accountability. And I provide these to you because I think they're valuable resources and information specific to this topic. The ICCH GCP guidelines, I think the first three there provide a lot of information that can help, where, what, and how consent documentation should be conducted and filed. The next couple of few have to do with OCP and OIA. Really good sources of information, especially I think for Casey's group. They provide a lot of good information about consent and consent processes, forms, templates, a lot of questions. And then our site also does provide good guidance. So be sure to look at those links if you haven't. And then lastly, I think it's really important that you read 340.1. Informed consent for human research. It gives you good information. It tells you when things have to be uploaded into the participant's medical record. So you don't always have to, but it does tell you when you do. So I think it's good to know about that. Oops, pardon me. I switched through it so quickly. I don't know what happened there. And then lastly, at the bottom there, ICH is going to be releasing their R3 addendum to GCP E6. And basically what it's doing is it's employing state-of-the-art technologies now. It's addressing, all the different aspects that technology brings to the conduct of a clinical trial. So it would be good to become familiar with that. And it's supposedly supposed to be released in 2024, so they say. We're now in mid-October, so I'm not sure if they're going to make it. But nonetheless, it's good stuff. So this has nothing to do with informed consent. This has to do with shameless commerce. We're having our Compliance Awareness Week coming up October 28th through the 31st. And we have fun with this. We hold a couple of fairs. One will be at Jacobs Medical Center and then at Hillcrest. So what happens is we have our teams and we set up little tents for each team, and we have games and prizes and food and giveaways and such. But don't expect lunch, but we do have some little snacks available. It's very fun. So it's a camaraderie builder. It's always good to see research teams out there, and good to put a face and a name together. I enjoy it a lot. The kickoff webinar will be on Monday, the 28th at 9:30. It's a half hour. And Patty Mason and Ron Skillens, our CCPO, they'll be speaking. So keep an eye out for our email about Compliance Awareness Week, and I sure do hope to see you all out there. Do. So thanks for joining us. My presentation is short. I hope you found it valuable. If you have any questions, contact us or OIA for more information about this topic, or for any questions you might have about the conduct of research at UCSD. And that's it for me. Thank you, and back to you.